Hello, this is Dr. Faustino, your professor and instructor for your Psychology 633 Evaluating and Treating Sex Offender course. This audio lecture is for week 5 and 6. However, I will be flipping the chapters. We're going to talk about week 5 and 6 at week 4 when we meet this coming weekend. And I will record a video that's supposed to be for week 4, and it's going to go to week 5 and 6 during the weekend that we're not meeting. So all you need to do is listen to this audio file, audio recording, and this will count as your class. And also continue with your discussion post and or assignment that is scheduled for this week. So in moving along, we're going to talk about the chapter which has everything to do with program evaluation, which includes individual and group psychotherapy. So the area of focus will be group process of therapy with sex offenders, the key elements needed to do a competent group therapy. What are the psychologist qualities that you need and should possess when dealing with not only a normal client or patient, but a sex offender on top of that? And what is the structural integrity that you need for the therapy itself? So the primary goal of this chapter is discuss the cognitive errors in people's thinking, why, what mistakes they made throughout the process prior to committing the crime, reduce reoffending behaviors, reduce recidivism rate. That could be systemic, and it's not necessarily individualistic, but it could be both. Conform to societal expectations, because the majority of these sex offenders will be serving time, and when they finish their time, they most likely will be released back to society, to our communities. What are those expectations? So we'll cover as much as possible and make preparations to release back to community. So these are the focuses, or the goals that we need to accomplish during our sessions with each individual client with a sex offense crime. So, psychologists' approach to group therapy. Now, remember that this is in correlation and incongruent with the PowerPoint, which is provided to you as well as alongside this audio recording. So the preferred approaches: structured theoretical orientation. So this could be cognitive behavior therapy, which I believe most of you are familiar with and probably utilize this in your own practicum at this time. Behavior therapy, which you're supposed to do because it's a small component, or it's not a small component, but it's a big component of CBT. Psychodynamic therapy, which we do kind of use along with CBT to gather information about the person's history and a person's, not only personal or interpersonal, but family history, religious history, sex offender history, sex offenses history, arrest record, medical history, medication history, and it goes on and on and on. So it's important to get as many history as much as possible, including medical records. So again, we're going to talk a little bit about that too, but this is a preference, mind you, that it depends on your own personality, your character, your approach. So your preference is what makes you stand out as a clinician, as a psychologist. And solution-focused therapy. So we're not going to cover the whole gamut of theoretical orientation that's structured, because this is just more individual therapy. And then if you actually kind of go Beyond that, to systemic systems or family systemic systems, then we're looking at structural therapy approach, strategic approach, experiential approach, narrative approach, and even communications approach, or it's similar to experiential with satire. The riskier approach are a little bit more laid back, and that's kind of how I see it. Is, there are much more structured approaches with techniques, but then the riskier approaches have very little techniques built into it, but at the same time, they're much more laid back, and that's kind of how the approach is. We're talking about client-centered approach or therapy by Carl Rogers, or people call it Rogerian therapy, or person-centered therapy, narrative therapy, as I mentioned, experiential therapy, and psychoanalytic therapy, which takes the longest and the first and the foremost of all therapy by Sigmund Freud and Carl Jung. So there are these approaches that are preference based on what your approach is to that specific client. Mind you that each approach has to be tailored to the client and the client's problems, regardless of any sex offenses or any problems. All right? So it's easier if you actually look at the PowerPoint and follow the lecture according to it, because I'm following it as we speak. So there's a picture next of a group therapy with sex offenders, and typically this happens inside the unit, like inside the jails or prisons, where group therapy is typically when you form circles, and the psychologist or therapist is the one who's running or facilitating these groups. And again, most of you probably have taken group therapy before already. If you haven't, you'll figure that out when you do take it and you experience group therapy in your practicum and or internship. So a lot of the time there are rules that needs to be made with group therapy, even with sex offenders, because part of that is having a solid structure that clients, including the clients with sex offenses, will not get out of hand. The last thing you want is a client or clients, when the group kind of gets out of hand, talking about anything and everything they want to talk about, and there's no structure. So rules have to be made. But before we get to that, the next slide talks about the kind of therapy that you have to promote. First is conjoint therapy. Conjoint therapy is treatment format in which the client is seen by one therapist in individual therapy, that could be you, and a different therapist and a group therapist. Okay? The thing about this is with conjoint therapy, one psychologist is seeing him or her in, say, individual, and then you're seeing the person in group. So there's two different therapists or psychologists seeing the same kind of client. So it's a little bit more, detached. And the reason why I'm saying that is because you need to get an ROI to talk to the group therapist or individual therapist that the client is seeing, because you want information to make sure that your therapy is pretty much the same, in the same parallel as the one that they're using at the same time. Now, some psychologists in prison, kind of like myself, who've done this a multitude of times, do combined therapy. The client is treated by the same psychologist or therapist in both the individual and group therapy. So there are advantages to that, and we're going to talk about that too. So what are the qualities of psychologists? You, the person who's treating these sex offenders. And again, we're going to focus the client on sex offenders and their sex offenses. So you need to be warm, respectful, genuine. That means authentic. And you have to be true to yourself. You're not putting a false self towards the clients or the individual or group. Because a lot of these people are masters of reading behavior. And what I mean by that is that they can tell if you're lying. They can tell if you're faking it. Okay? So, caring, honest, objective, confident, knows limit setting, that includes setting boundaries, and non-judgmental. We're not there to, you know, put him down. We're not there to, make him more, of a quality of a sex offender, or keep calling him you're a sex offender and so forth like that. And the word that I've used before is chomo, okay? Child molester, okay, for the most part. Because a lot of the time they have these titles inside jails and prison. But even in the court system, again, where do they stay if they're going to courts for trials and sentencings and all that? In jails. So jails are meant for processing, and then after they get sentenced, they get sent to prison. So you have to have the qualities of a genuine therapist or psychologist. And the reason why that helps is because you are neutral. You're not judgmental. You may have authority based on the authority given to you by a governmental agency like the federal government, the California State Prison, or San Bernardino or Los Angeles jail. So you have a certain title and authority. And even your doctor title speaks volumes about what your authority is. But that doesn't mean that you have to be demeaning. You have to be mean to these clients with sex offenses and so forth. They already have, at the tail end of being mistreated inside jails and prison. Okay? So we're going to talk a little bit about that too. In 2 weeks before this, we're going to talk about that too, because we're going to emphasize why they're at the butt end, excuse my language, of, the hierarchy inside the prison. But the other qualities that you should not possess, again, this is counterpart to what I just said, is you should not be too critical, too sarcastic, okay? Because it would show in your intonation, in your voice, in your statements, in your questions. Judgmental. We're not there to judge them. They've already been judged by the court. And the reason why they're there in jails or prison is because they've been sentenced and they're there to serve time. There's no need to add more punishment. And again, they're being punished for being there already. And they know that. Having an attitude problem, being bossy, being narcissistic, too codependent on the client that you need to see them because that will show, and doing favors to the client, which is something you don't want to do, okay, because you're seeing one client more so than the other clients, and everybody knows this. So one thing that I think I talked to you guys about already is when you're inside working with sex offenders, especially inside the jails and prison, everybody notices everybody's behavior. You're being observed 24/7. Watch what you say, watch what you do, how you dress, how you walk, who do you talk to, who do you affiliate with. All of these are being observed. And you are there to be professional, to be neutral, and to be objective. You don't want to be too subjective, especially in group therapy where everyone, and including individual therapy, everyone is sharing stories about themselves. So what are the qualities in group therapy that you want to kind of control is that people overshare. They tend to overshare stories because try to imagine a group of 6 to say 8 people who are all sex offenders in your group. They all have similar qualities and commonalities. And the problem with that is that they tend to overshare because it's bragging rights for a lot of these people. How many times have I heard, how many children did you molest? And how did you get away with it? And what did you do? And what did you use to tie them? And what did you use to drug them? And, what did you do to entice them and so forth? They're sharing stories it's like, a group of friends who hasn't seen themselves in a long, long time. And you want to control for those narrative. Only because if that comes to the point, then you've lost control. Remember, group is meant for a purpose and a reason. And what I mean by that is when they're there for a reason is to get better, to confront some issues, especially emotions, especially trauma, and all of that. So, being subjective, talking too much. If you see yourself talking too much, explaining, especially interpreting, I caution you. Hold back. Watch what you say and what you do. Because it's important that they talk. They share the stories. It's their histories, not yours. Okay? When that case where it's overturned and you are doing more of the talking, explaining, interpreting, do you think it's still considered therapy? Most likely it's not. So you should reevaluate your approach and you should look into how can I change this so that they're going to do most of the narrative. So again, I'm back to that 80-20 rule. 80% of the work has to be done by the clients in therapy. So it should only be 20% of your job doing it. Controlling, guiding, modulating, assessing, all of these other things that we do. So these are qualities that we possess. You also don't want to be too detached, robotic. Okay, your response is very monotone. Okay, be yourself. Remember, you're dealing with human beings, even though that they have sex offenses, because a sex offense is a crime. So you have to have that right balance of talking and listening. And then the other part to that is not only being too detached, is you're too quiet. You haven't said anything in the last 15 minutes of a 60 minute group. So it's always a good idea in the very beginning, if you're not used to group therapy, having these qualities is that you should have a co-therapist. It's mandatory. Because one, you're not sure of the time and how to use it and how to guide them in all of these things. So having a co-therapist who sits across from you is very important, because this way you can monitor every behavior that happens. And we're going to talk more about that too. All right? So I hope that I'm making sense as I explain this. So individual therapy is used to augment or facilitate the course of group therapy, and vice versa. So again, we're talking about the compound therapy. If I'm seeing this client who's a sex offender, and I know that because a lot of the time sex offenders are 8 to 9 out of 10 males, okay? So the high proportion and disproportionate of males over females. Not that you cannot do women's group or sex offenses with sex offenses. But the thing about this is there's not a lot of them to form a group, whereas in male prisons or jails, there's enough of them to facilitate a group after group after group. So when you're facilitating that, you're augmenting, and you're seeing a client with a sex offense, an individual, you know his issues. And then you're augmenting, having him signed to your group therapy, also with sex offenders. So the reason why we do the individual and then the group therapy is to promote the skills that they're learning in individual therapy to group therapy. How do you now practice that around other people? Does that make sense? Right? So you could have a lot of conversation with a client about his issues with sex offenses, with trauma, with, why they did it, and so forth and so forth. But the thing about it is, how do they practice it? How do you know they're mastering the skill to say, if you are put in the same situation again when you are released from prison and you go back to community and you encounter the same situation that put you here in the first place, what alternative behavior or decision making do you do? We promote that in group therapy. So we test those skills of those sex offenders in group therapy. And that's why this works so well, because I can see, and the client, I think if you think about this, the client cannot really lie in front of you. He may lie in front of the other sex offenders, okay? But if that client who you know that you're treating an individual, if he lies, what do you think is going to happen? You know his issues, as well as he does. So in group therapy. So it's to practice those skills and to avoid the lie and minimize it so they're accountable for their behavior. Now, you can have all 6 in your individual as well, or you can have a combination of that. So, clients refer to group therapy because they have improved in the safe setting of one-to-one therapy, yet unable to transfer learning to outside life. So this medium of group therapy is the test. It's the test so that they know, like, if this situation comes up again, what are you going to do? What are you thinking? What are you feeling? What decisions are you going to make? And what actions are you going to do? So you're testing them, step by step before they actually go back to the community. Now, in the community, we emphasize also that, they pursue outpatient therapy. That means the sex offender class and the individual therapy and the group therapy and all of that they were attending to while in jails and prison are also continued on the outside. Okay, it doesn't end because we contact probation, we contact parole office and all of that. We want to make sure that the same groups that we're doing inside are followed through on the outside. Okay, these people are not well. Okay, so we're going to talk more about this in week 4 because there's going to be videos that I'm going to be showing you so forth like that. But we're going to talk more about the qualities of a sex offender. So it's important for you to recognize that, these are the things that we're supposed to do and responsible for. So the next one is a pre-selection interview. Why do we need to do a pre-selection? Well, pre-selection of group members. We're not just going to put, well, you have a sex offense, you're in my group. You have a sex offense, you're in my group. Okay? There are different commonalities and differences among sex offenders. I would like to put people with similar personalities, similar crimes, cooperativeness, and goal-orientedness. So I'm not going to put, I have 6, sex offenders, who are pedophiles, child molesters, and then I'm going to have, another 6 who are, adult women rapists. Because the issues may be different because one, it's centered on children, the other one is centered on female gender only. So there's going to be differences. So even that, I can have 2 different groups doing that. So the crimes are going to be similar. Are they cooperative? Now, I've run groups of sex offenders who are very argumentative. So imagine that. Imagine if I'm having 6 cooperative sex offenders and 6 argumentative sex offenders. Of course, the sex offenders who are argumentative want to control the group. I'm going to take more time setting rules, controlling the group. We're not going to get much done. So it's important for you to recognize, because pre-selection is in your control. It's in the psychologist's control. How many people do you want in that group? 6, 10? The average is 10 to 12. And then it can go for groups, it can go all the way to up to 16. The pre-selection is also important. And why do I say this? Because again, there's going to be a line of clients with sex offenders. Let's say you have 30. Are you really going to run a 30-man group? No. By yourself? Impossible. So the larger the group, the more co-therapists you will use and enlist to assist you, maybe 2 other psychologists, maybe 2 interns or master's level clinicians. Okay? It's your choice. And pre-selection also dictates that there has to be a primary psychologist running this group. And that means it's you. You make the final decisions. But the other team members that you bring in are part of your team. So that means there's going to be a group coherency among staff and faculty running the group. And then you can pre-select the members. So that means if I have a 30 member or a group member that's in a waiting list, okay, it's important to figure out who is the most ideal for this group that I'm running. I'll give you a perfect example. So I'm running a sex offender group from 18 to 32. That's it. So age limit is a marker. 18 to 32. So anything from 32 to 65, that's a separate group because that's an older group, the older men's group. Okay? Males. I'm not going to combine men and women, especially even on the outside in the community. Because in prisons and jails, men and women are separate. But in a community, you can combine both. But preferably, you want to separate the men and women sex offenders. So even the pre-selection is very, very important because it speaks volumes of controlling for the issues and the behavior and the personalities and the crimes. And, again, the next one is goal-oriented. Are they goal-oriented? So what if 10 of my, enlisted group members, they're violent. They're violent towards their victims. And they're uncooperative. They're, in the last group, they fail to show up. They're inconsistent with, appointments. And they're always late showing up for groups. Do I want to bring those people in? Because pre-selection involves pre-interview. Okay, this is important in group therapy. You're doing pre-interview because it's important to assess and get a feel, is this client fitting the criteria for my pre-selected group that I'm going to run, let's say in 4 weeks from now. So you're doing this in advance. So I hope that's making sense so far, right? So be aware of disruptive, influential, counselor type of sex offenders, SOF. So you're always going to, we're going to talk about this too, you're always going to have clients, okay? And I'm going to stop talking about clients with sex offenses because I think everyone knows what I'm talking about here. Clients who are too narcissistic, antisocial, bullying behavior. You need to be aware of that. So if that's the case, then I may add that one person amongst sheep of other passive or passive-aggressive clients, okay? Or I may not include that person at all. It's my decision to make. Do I want to make the group difficult? Do I want to make it medium? Do I want to make it too easy? It's all questions for the psychologist on how you want to run your group. And remember, this is a separate sex offender group. You're not going to include other crimes there. You're not going to have drug dealers. You're not going to have, murderers. So I want to keep it as close and small as possible because that commonality speaks volumes. Be aware of people who are too loud, too vocal, too demanding because they want to run the group. A lot of these people, are masters at behavior. They're antisocial. They're narcissists. Some of them could be borderline. So they belong in a cluster B of the DSM's personality disorder. So a lot of the time, too, they have a goal. They want to run the group. They want to be junior counselors, junior psychologists. This is the danger to that because they're, sucking up to you and they're like, oh, they're doing the work and they're doing a lot of, intervention in group and so forth. And you have to be mindful. Are they doing me a favor or are they really trying to run the group for me and I'm just lazy to run the group by myself or with my therapist? So you got to be mindful of that because they're going to be too demanding. They're making demands of the others, because they feel that, hey, I'm older, I have more sex offenses, I'm just louder. And a lot of the time people want to follow this kind of behavior and they're doing so already inside the prison. Okay, the loudest and the toughest and the strongest and the most that tattooed, all of that, they tend to stay out of these people's way. And they can have their own separate groups. I can have 4 people who are loud and obnoxious and narcissists and antisocial. Okay, I can control that because 4 of you versus 2 or 3 of us who's running the group. And I'm going to be setting limits all the time. So there are ways to manage people's behavior where you can have a good mixture of both. Okay? So it's important to just be aware of the qualities of how and what qualities does your group members possess. Because it's important for you to pre-select this in advance so that you have a similarity of these people, weeks and weeks in advance. All right? So again, pre-meeting, there's going to be pre-interview with you or your co-therapist or your whole committee. So let's say I have 2 co-therapists. I'm going to pull them in, and we're going to each interview individual, and we're going to say yay or nay. Yay for the next group, and nay, maybe not this group, but the next group. Okay? So as you do this, you're going to have an outline of assessment or just questions that fits the criteria for your group. How many group sessions are you going to run? The average is 10 to 12 for individual and usually 12 to 16 for groups. And the reason why we have more group sessions is because the list that you're going to have, let's say that I have 30 in a waiting list. Okay? I'm trying to fill a 16-man group, but I'm going to put 18. I'm going to include 18, and I'm going to exclude the rest. The reason why I'm including only 18 is because if I do start the group, there's always a potential for someone dropping out. Okay? When someone drops out, the numbers decreases. Well, like I'm going to court next week, and I forgot to tell you, and I'm going to be out for a month, so there goes one member. Or I forget to tell you that, I have education class that coincides with your group, so I can't make it. That's another one. So there's always a potential for people dropping out. And then a lot of the times you lose a couple of people and you're still well below the 16 marker that you instituted. And it could be less. It's up to you, right? But you need to explain to the members how long the sessions are. So my typical group therapy with sex offenders will be a 90-minute group session with a couple of breaks. About 10 to 15-minute bathroom break, but it's 90 minutes of group processing. And that's a combination of didactic lecture and group process therapy. So it's important for you to inform the clients of that, because they also, inside the prisons and jails, they have other schedules. They have to go to their GED classes. They have to go to HVAC to work. And even if they're only making 5 cents an hour, it's still work, and they're mandated to work. Okay? They have to meet with a counselor with their case management, for their court schedules and all of these things. So there's, even sex offenders are quite busy inside. Okay? So you're squeezing yourself in to see if they can meet your schedule. So you have to explain all of this, the number of sessions, how long is the sessions, where is it going to be held. A lot of the time when I work for a psychology department, we have a group room designed for that. Okay, so that means that when we start the group group door is closed. No one is allowed to get in. Okay, and that means that, they know that 9 o'clock every Tuesday, that's when the group starts for 90 minutes, is the time when it starts. That means I'm sending out emails to their counselors or whoever's in charge of them to ensure that they make sure that they attend the group that they sign up for. So all of these little details is important. And then, with the pre-meeting, there's going to be a post-meeting. That means that you can now announce to them, as I have many, many times, that, hey, you're now accepted to the group. This is the rules for the group. I'm giving them a handout, a folder, with blank sheets of paper, or a notebook that's kind of cheap, that's provided by the government, a pencil, and the schedule of the group and what we're going to be covering, not necessarily specific ones, of course. So they're going to meet with you, and then they're also going to meet with, with the start of the group, when it's supposed to start, from when to when, how many sessions. Once a week, twice a week, on weekends, all of these specifics are given to them. So everything is in detail, okay? So it's more structured than the ones that's outside in therapy for outpatient basis. So, the inpatient basis, especially in jails and prisons, are much more structured. So just giving you a heads up on what those qualities are and what you're supposed to do. So the typology of a sex offender are based on theories postulating that sex offenders specialize in child abuse, fixated, regressed, victim, gender related, or relationship. So a lot of these chomos, and again, this is a prison word, chomo, child molester, and all the inmates know this, and the staff and faculty and you as well know this, that they're regressed individuals. You know, they do what? Out of love for the victims, the children, boys or girls or both, according to the DSM. They're rapists. Power reassurance, power assertive, anger retaliation, sadistic. These rapists could be also rapists of children, adolescent, or even adults. So it varies in terms of age, but they have a specific preference. So these are typologies of sex offenders. So you won't see a lot of females, a lot of sex offenders that prefers women, but they also go around, sexually assaulting boys and girls. So their preference is pretty much fixated for the most part. There's also a classification for female sex offenders. So you'll see about 2 out of 10, 1 out of 10 of those women in prison are female sex offenders. Their co-offender also happen to be another sex offender. Their teacher, lover, heterosexual nurturer. Again, they do it out of love. Some of the excuses that I've heard from my female predators who molested teenagers and children is because they were not nurtured by their parents, and only they can give the love and structure and nurturance to these victims. So again, the mentality is similar, but the justification could be very different at the same time. And then you also have the internet, which is there's a small group of these individuals. They're the impulsive, curious. They're going into the dark web. Okay, the one that I mentioned before in class 2 weeks ago, NAMBLA. Okay, who are the men-loving boys. And they do the justification because out of love. They molest because they're doing it for love. Even though we know it's morally, wrong, but in their mind it's right. Fueling sexual interest, accessing victims, disseminating images. This is what I've told so many parents. People post their children's pictures all the time. When you post children's pictures, it's out in the public. You cannot take it back. And a lot of these sex offenders have access to those pictures. There's millions and billions of pictures of children floating around. And they fantasize about those things. Okay? So again, we want to caution parents, and sometimes we may have to talk to these parents as well, of the victims. Seeking financial gain. What do they do with these pictures? They trade them like baseball cards. They trade videos. They sell and buy in the dark web. So we know these people have access to these things, and they have access, and that fuels their fantasies until they get caught. That's the important thing about these things. So it's important for us to acknowledge that these are the kind of behaviors, typologies that we're looking for. And there could be things that's in between or a combination of these things as well. So these are the kind of things we are mindful of when it comes to the DSM-5 TR. There's the Access 1 and 2, and again, I just kind of separated it, but it's more important for us to really pay attention to these things by category. Depression category, anxiety, trauma, psychosis, which includes schizophrenia, adjustment disorder, feeding and eating disorder. Some of them could be anorexic and they have binge eating problems, sleep-wake disorders. That means they're having issues with sleeping because it's their first week or first month in prison. Intermittent explosive disorder because of anger, they got caught, and all of these other things. So again, you're going to encounter a lot of these issues, and you may use these diagnoses in a combination. But of course, you also have to focus on the Axis B, which is your personality disorders. Your cluster B is the most common and most popular. These are your antisocial, your narcissistic personality, your borderline and histrionic personality. Your cluster A is your paranoid, schizotypal, schizoid, which is rare even in prison settings, but you do encounter them. Cluster C, even more rare, avoidant personality, obsessive compulsive personality, and dependent personality disorder. These are even less than A or B. So again, I'm just giving you some categories on what to look for and what to use, because you are going to end up diagnosing these individuals. Okay, you may not be the first psychologist to diagnose and treat these individuals, but you're going to end up doing a group, or you're going to see them for intake, or you're going to see them for individual therapy. And you're going to justify your justification of why you're seeing them because a lot of the time these people need help, assistance, mental health care is deteriorating inside. No one wants to talk to these individuals. They're blacklisted. Okay, so a lot of the time, even though they're surrounded by other inmates, they're lonely. Okay, and they have needs. So they're at a point, or they're put in a position inside jails and prisons where they can no longer have access to their victims. They got caught. So that fuel of fantasy, even though they have a high sexual drive, what do you think is going to happen? They're going to, get irritable, frustrated, act out, okay? Even become more violent, because a lot of these other inmates are going to push their limits. And a lot of that time, they may not make it mentally. That means they're experiencing severe depression, severe anxiety, severe loneliness. Okay, their families may even don't want to have anything to do with them. So if the other inmates are isolating them, and their families don't want to be in touch with them or visit them, so what do you think is going to happen? There's a potential for suicide. So again, you're always minding that these clients can be a vulnerable group. So that's something to watch out for. So, moving on. Experimentation with behavior in a low-risk environment. That's what group is about. Okay, going back to the group topic. Experimentation with behavior in a low-risk environment. I said it for a second time. Is that groups are meant to be a medium where they will test what they learn in individual therapy. If they succeed or not, we're about to find out. Okay? The intensification of countertransference in group therapy, GT, rather than individual therapists. That means that they practice with you and you practice confronting them. Let's say that I can do a role play with a sex offender in individual therapy to say that, okay, so how do we do an employer interview? You're looking for a job. Because these people do want to work. They want to go back to society. They're already stigmatized by other people. And they're going to be further stigmatized when they get out. But we can role play a situation where you're being interviewed by an employer who's willing to hire you, right? Because we did this in advance. We sent the application. They know you're a sex offender, right? You're not going to lie about that. But they're still willing to take you. So how do you go through the interview? Develop a CV or a curriculum vitae or your resume. We can develop that during the prison, during the time you're in prison with education, helping getting assistance with writing skills. So we can de-intensify the situation, the special situation that could happen in the near future with an employer asking you questions about your sex offense and your work qualities and this and this and that. So we can do that, and more so in group therapy than individual therapy. Do you see how that could work? So it's important for us to role play and test the ability of the client so that they're prepared for the near future. Remember what I said before. They will, of course, get released back into community. About 85, maybe close to 90% of these people will go back to community after they serve their time. Group peers and individual therapists serves as peer consultants. So when you have a 12-member client in a group, they can check each other out. So this is where you have to be careful about other people egging them on about their sex offenses, and because they're learning from each other. So group is about learning new skills that's not promoting negativity, new skills that will make them better citizens, so that they can get out and get a job and function out there and not reoffend again, and lower recidivism rate, and so forth and so forth. So it's important that group peers are also pro-social, in terms of the values that you possess, because you're the one who's modeling these behaviors. You and your co-therapist are doing that. So when others follow your modeling positive behavior, then others will follow. So this is where the other group members serves as peer consultants to say, yes, so I don't need to be negative all the time. I don't want to go back to prison. I want to stay out there after I serve my time. Okay, so that means I need to do what I need to do to work on my issues. So I'm going to take a quick break for a second here. Please get your coffee, take a break for a second here. I'll be right back. All right, let's pick up where we left off. So on the next slide is it's called Maturity of the Sex Offender. Are you doing groups of juveniles versus adults or both? So it's preferable that you need to assess for cognitive and emotional maturity. So preferable when you're working in juvenile halls, it's all going to be juvenile, so that's easy. And when you're working with adults, it's going to be also easy because they're adults, so you're not going to be combining adults and juveniles. But then there's also the case where there's going to be young adults who are juvenile, sex offenders, and then there's going to be adult sex offenders. So you need to assess for cognitive maturity, the education, the social skills. Are they able to control their impulses, their temper? Emotional maturity, recognition of various emotions. Because the younger they are, especially juveniles, the more that they're not able to recognize the difference between, say, anxiety and anger, frustration, agitation, impulsiveness. So all of these other things that are required to maintain a behavior that is, standardized for any group member, that at least you're participating and you're not acting out, you're not walking away, you're not throwing tantrums or anything like that. And that's part of assessing for temperament. So it's always important for the psychologist to assess for those two levels of maturity, and then part of your assessment will go into that. So it's underlined in the next one, the ability of sex offender to understand therapeutic concepts. So if they're unable to understand that, are you going to put them in a group regardless? Probably not. Most likely not. Because if they cannot understand concepts of emotions or guilt or shame or regret, these are emotions that's tied to their crime and towards the victim and so forth. What do you expect them to learn, right? So it's important for you to assess that as well. Are they able to learn? So part of that is the cognitive maturity education assessment. Are they able to accept and learn something new? Or the ability of sex offender to self-reflect. So this is self-awareness. It's important for us to assess and include that, because if they're not self-aware, then what are you doing group for? Why are we doing individual therapy for if you're not learning anything, if you cannot self-reflect that these are the wrong things that led to your decision and why you're in prison or jail? So again, it's important for us to do these assessments. The next picture is just another group picture of a psychologist somewhere in the top right here, and then surrounded by, of course, other members in group. Complications. Okay, and again, you may review this already. You may recognize these concepts already as being part of the group therapy that you've taken in the past or recently. So synthesis of individual and group therapy is necessary for success. It's important to do both, okay? Because doing only one can be successful also, but you want to have more success, more information, more learning, so the learning curve is going to be greater. So for individual therapy, biofeedback therapy, if you know how to practice biofeedback, and it doesn't have to be solely, biofeedback itself. There are different forms of biofeedback. And then also with group therapy, the combination with CBT. Okay, so if those two are not compatible, meaning the approach is not compatible, then the result will be client confusion, because they cannot integrate what they're learning into one, in individual therapy, versus the other one, which is group therapy. So it has to be compatible. The approach has to be compatible. All right. So the comparison of individual therapy being greater than group therapy is not really what we're after. What we're after is synthesis of learning. What we're looking for is the ability of the client to self-reflect, to increase growth, to self-reflect, to learn from his mistakes or her mistakes as well. Client resistant to work in group therapy, but thrives on venting group therapy issues in individual therapy. These are some of the things that you will encounter. Resistance is a big word that we use in therapy all the time. Client not showing up on time, in your therapy, that's resistance. Client not showing up an appointment at all, or rescheduling constantly, that's resistance. Okay, client having a rebuttal and being sarcastic and seems angry all the time, that's a resistance. So there are many forms of resistance, but the thing is we have to understand this client resistance, where is it coming from, because their growth is stagnated if that's the case. So the other side of that is client resistance to vent to group therapy on issues that she has in individual therapy. Why are they holding back? What's the reason for that? Okay, maybe they're embarrassed. Maybe they're not used to role playing. Maybe they're not used to being heard by other, sex offenders as well. Because in group therapy, you are vulnerable. You have to open up, just like in individual therapy. But with group therapy, it's more embarrassing if you open up and are embarrassed talking about your issues, especially if other people are shaming you and embarrassing you. There's none of that. Part of the rule is, we're going to talk about these issues openly, but there's no taunting, there's no embarrassing, there's no shaming other people, blaming other people. There's none of that. Even from the psychologist like yourself who's running the groups, there shouldn't be any of that. It's about openness. It's about building trust. So it's important to do this as well as what you do in individual therapy. Group therapy should not be used as a cover for passing clinical responsibility due to impending termination. So it's important that, remember, I'm running a 16-session group therapy for sex offender 18 to 32. So it's not used to just, hey, I'm just going to vent out, and I'm not going to learn anything, and my time's running out because in 2 weeks I have to quit this group because I'm going back to court and I'm being released. Okay, so if there's no growth and no movement, then what are you doing group for? So you're always assessing every session with these clients, putting your notes in, documenting these things, whether there's growth or there's not. And it's not used to cover for passing clinical responsibility due to impending termination. That includes your responsibility as a psychologist, as the group therapist, as the primary group therapist. That means like, oh, you know what? I only have 2 sessions left. I'm going to let my master's clinician run it. I don't have time for this. That includes that also. That means your responsibility is you started this group and you're going to finish this group unless it's a dire emergency. Okay? And very often in my experience, I've never had to cancel groups because I love doing groups, because it's very, beneficial for us. And it, you get to expand your skills as well, your skill set as a clinician. Okay, moving to the next one, pairing of less experienced therapists with senior therapists. So if you don't have the experience, I would suggest finding someone who's more experienced and you can learn from that person. That could be your clinical supervisor. And then once you're experienced yourself, then you're going to be training new ones, new psychologists in training, maybe master's level, maybe interns and all of that. So you want to pair those two. Okay, and the conditions as having group therapists as open, solid, mutually respected relationships. Okay, that means that all of those rules that we emphasize in the very beginning, it's important to follow through with that, to say, hey, you know what? That becomes part of your rules. The rules are emphasized from the very beginning, and it's standardized every session. There is no bending rules. Okay? And one of my number 1 rules is no violence. Another rule, everyone participates. If you didn't talk today in today's group, if we're having group tomorrow you're gonna be the first person to talk tomorrow. So it's important that everyone has an active participation sharing of these things. right? So you can develop these rules and you can create your own rules as well. But, again, a lot of these combination of rule setting is I'm going to create my own rules, but then I'm going to ask this group to also add to these rules because they may be creative and inventive about these things. So they're going to add more to the rules. But with every rule, there's consequences. If you break a cardinal rule like violence, then you're automatically out of the group. Okay? Or you haven't spoken in a long time, and now we're forcing you to speak because you signed up for the group and you initialed that you're going to participate in all that. You chose not to. There's going to be consequences to that, right? You may have to repeat the group again in the next turn. So again, there's going to be consequences. But the consequences also, and again, we talked about this in other classes, since you've been with me for other classes, okay, is there's the reward system. So there's nothing wrong with talking about the issues as processing these clients' issues and all of that, abuse, neglect, trauma, whatever. We understand that. But then, of course, I'm going to be giving compliments as well. Okay, I'm not going to be giving candies or anything like that. But I'm going to be sharing information, maybe some documents, and that includes like, some chapters that I'm copying for, like sayings. I love doing that. Like sayings, like important sayings, it's got like fortune cookies and metaphors. I'm going to print that. I'm going to give it all out, copies and all of these things. They can put them in their folder. Okay. In the end, I can give certificates for completion of the group. And a lot of the time, if they like your group, they're going to want to pair with you again for the next group and the next group and the next group because it's all about learning. It's all about positive role modelship that you and your co-therapist are manifesting out there with them. So again, there's that good relationship. And then also a complement of individual therapy and group therapy, the combination of both. So the combined therapy that we talked about, placing client into group, generally composed entirely of mostly of clients who are individual therapy with the same leader, that's you. Typically, client attends one group session and one individual session weekly. So it's kind of a little bit more, standardized here because you want to be up on their issues at the same time. So you don't want to have that one session with a group and one session with individual therapy too far apart. Okay. Cohesiveness. So it's important to talk about cohesiveness because the degree to which group members bond with each other. Yes, most of the time, cohesiveness is a goal in any group. Okay. But you have to be aware that they're going to get to know each other's issues. And one of the things that we talk about in rules, in rule setting, is confidentiality. What's said in the group stays in this group. Because you don't want those issues, being broadcast to other inmates because that could put them into danger. So everything stays within the group. And there's penalties for that as well. Okay, how many times have I penalized people who broke the rules, the cardinal rule, and then I ended up putting them in isolation because they were put into danger. Okay, so that means they put other people at risk and they had to be punished and all that. And they weren't thinking because they were just, vindictive about these things. So again, sometimes these issues come out. Work with one another to achieve their goal. It's about the group community. Okay, it's not individual, you're functioning as a group member of that group community. So it's important to emphasize that as well in the very beginning. And you'll also have to be wary of codependencies. So we're going to talk more about groups, in other classes too. But part of that too is the codependency. You may notice that the same people sit next to each other all the time, week after week, day after day. So you want to break that apart to say, hey, you know what? Are they lovers? What's going on here? Are they too codependent? Are they're finishing each other's word? What's going on here? So again, you're mindful of these things as well as your co-therapist. Expressiveness measures the comfortable openness of group members to talk about important issues, not just superficial issues. Participate in discussion, questions, okay? Opinions are welcome, and express one's feelings. So that means they have to be genuine about these things. And danger of bragging rights. In the very beginning or throughout group therapy, that's one of the things you have to be mindful of. Are they there to brag about their crime? If that's the case, then let me talk to you after this group or now. I'm going to pull you on the side, and we're allowed to do that. I'm going to pull you out. Let's talk outside. What are you doing? That's not part of the rules. That's not part of the goals of this group and so forth. And it's going to be your final decision whether you want to consult with your co-therapist or not to remove this client from this group, or maybe just give them a timeout. It's really up to you. But sometimes that's one of the dangers, because these people, again, they have special crimes. Okay? A lot of the other inmates don't understand, because a lot of the inmates have labeled these people, again, as chomos, even though these people that they're functioning or being in the unit where they live, or the dorms where they live, are murderers, terrorists, drug dealers and all of that. A lot of those people are also family oriented. They have children. They're very focused on their children's welfare. Even though they're murderers and terrorists and all of these things, these people will not allow children to be harmed. So that's why this population, this chomos or sex offenders, is a special population. You harm children. That's against their nature. That's why they're at the bottom of the totem pole. All right? Another picture of inmates doing group therapy. And in this case, it's going to be male group, but facilitated by female therapists on the far upper right. But there's also a person speaking on the left, probably a confrontational group, or maybe reading an essay or anything, something like that. So, and in the far right sitting is probably the psychologist treating as a program treatment coordinator in these group therapy. So again, we talked about this before, time limited, 12 sessions versus open-ended. Open-ended typically are your support groups. Your AA groups that's been going on for 25 years. That's not a group therapy. Okay, that's not a process group therapy. That's a support group. Okay, you're running a time-limited session because in the beginning, there has to be an ending. And these clients in that session knows it's going to end eventually. You're in session 8, 4 more sessions. You're in session 11. Next week is last session. They know it's going to end because it forces them to learn something. Okay, versus open-ended, they could be lazy about these things, taking their sweet little time. After termination of group therapy, client continues with individual with the therapist. So that could be longer lasting. So the 12 sessions, but you've been seeing them for 2 years. Again, a lot of these could happen inside the prison or jails, but if you do have a group therapy with sex offenders outside in the community, it's still going to be the same thing. It's going to be time limited. Okay, so out there in private practice or group practice, you could be billing for 12 sessions, and then you have another group coming up, and then another group right after that. So again, pretty much the issue of structure is standardized. Higher dropout rates of conjoined therapy versus combined therapy. When you have 2 different psychologists or therapists seeing the same client in individual group therapy, a lot of their issues are not talked about selectively by both therapists, versus you have one psychologist doing the individual and group therapy, so you know both of their issues. So the dropout rates are pretty much lower compared to conjoined therapy. With any group, there's going to be 2 dimensions. There's going to be you, the psychologist, primarily the leader. So I typically would call myself the primary group therapist or group leader. And then you're going to select 1 or 2 or more group therapists with you. Maybe, again, I talked about this before, an intern, another psychologist, a master's level clinician, like a counselor or so, and you're going to use them as your team. Now, there is differences between a single leader and a multiple leaders. So again, there's always going to be 3 or 4 of you, maybe 2, maybe 3, but at the same time, you're always going to have one primary leader leading the others. And you can switch too. I've done that many, many times. And that's strategic to say that the last 4 sessions, I was the primary group therapist, and then I'm training an intern or a new psychologist, and then I'm going to signal my new psychologist, or we're going to talk about this before the group starts, that you're going to be leading this group because I want you to enhance your skills. I want you to take over from me. So I'm going to sit back. Maybe I need to observe, another client throwing a temper tantrum, or maybe this person next to me sneaky. I need to observe their behaviors and all of these things. There's many reasons why I can step back as a group leader and not be the primary leader anymore, or I can have another person take over and so forth. So a lot of the time, that's that one dimension. The other dimension that I want to mention, that's something that you need to understand, is that within the client group themselves, someone or a few will always volunteer to lead the group, to be junior psychologists or junior counselors. It's important to do that. It's important to recognize that, because these people, again, as I said it earlier, are typically your bullies, typically the most vocal ones, the most educated ones, the most narcissistic ones, most borderline and antisocial, so they could be gang leaders for all we know. So a lot of the time they want to take over your group, and they want to do it subtly. So you have to be mindful of that 2 dimensions. You're running, and then they want to run your group for you, but at the same time, you always, always, always have the final say. You, your team of staff, your faculty, have the final say on what happens in this group. You can talk as fast as possible. You can slow it down. You can write. You can have homework assignments instead of talking. Whatever you want to do, as long as you're moving the group forward with their issues. They always have to have a forward momentum in talking about their issues. The group, session after session after session, cannot remain stagnant. Hear me out when I say that. There's no group they will just sit there and talk about nothing. That is not useful in treatment. They're not accomplishing any goals if that's the case. So be mindful, because you're also going to be responsible for that. So watch out for criticisms, defensiveness. And in terms of defensiveness, what are they covering up? What are they not willing to discuss? What are their feelings? What are their feelings behind that? What are their attitudes? What are people's confrontational style? What about the out of the loop? The person who's not wanting to talk, not wanting to volunteer information. They're just sitting there, staring at the floor, twiddling their thumb. What's that about? And there's ways to go to get information from those individuals. Okay? But again, and here's one way of doing that. When I have groups of people that's talking all the time, I'm always observing who's the one not participating, who's out of the loop. And it could be 1 or 2 or maybe more people. But a lot of the time, that person is going through something. And my question always to the group is, why is the group not paying attention to this person? Why is the group continuing to ignore this person? See, I'm more observant of that. So you don't need to listen to what's going on all the time. I'm listening to what's not happening in this group. So here's a technique I'm going to share with you, okay, that often is very useful in group therapy. So instead of me pointing out to this person who hasn't said anything at all, and then I'm going to put this, it's going to look like if I do this, I'm going to put this person on blast. Now this person's like, oh yeah, I don't know what's going on. I don't want to participate, whatever, And now everybody's going to stop. Now all the focus will be in that person. Now, am I really wanting to shame this person? Am I really wanting to put all the attention on this person because now all the talking and discussing has stopped? Or I can do that, okay? Or I can ask the group very subtly, Does anybody notice that a lot of people are not participating in your group? Some people are not willing to participate. Some people are more quiet than others, and they're all going to stop. And they're all going to look around to see who that person or persons will be who's not participating in their discussion. And then I'm going to allow them to talk to that person rather than me. So if you think about that dimension, if I put them on blast, they're going to get defensive. If I have the group not put them in blast, but pay attention to what's going on, why they're not participating, because they're their peers, right? I'm the authority figure. So if they're being confronted or challenged or being questioned by their peers, then it's probably more acceptable to actually answer and respond to that peer who's, questioning them. So, hey, why are you not talking with us and all of that? Why are you not discussing these things with us? Again, you can do two ways. It's going to be your choice. But I prefer the second, because I'd rather they talk to their peers. Okay? Because if I do it, I'm doing the work. And I don't want the client to be shamed. So, I hope that makes sense. Right? Too much disclosure. Are people oversharing? Or some people will take over and spend a lot of minutes talking about their issues. Remember, equal time for everyone. If I need to cut you off, I'm going to cut you off. I'm sorry. I'm more direct that way. And I could be subtle about it by saying something like, oh, I'm going to hold on a second. I want to hear from other people. Or I could say something more direct, right? To say, hey, could you shut up for a second? I want to hear from other people. I can do both approach. But the thing is, I'd rather be subtle about these things. So too much disclosure is something you have to be mindful. Holding back. So it's also another way of looking at if they're sharing, but they're not really telling the whole story. Too much or lack of empathy. They're crying. They're not showing emotion. So what's going on here? So these are something that you and your team, your other psychologist, your intern, your master's level clinician have to be mindful. You're always observing. You're always watching out for every minute nuances and behavior. And your group can run as short as 60 minutes, 45 minutes. Or it could run, the longest that I've ever run was typically like 2 hours, because I have a large group. And there was a lot of issues that they want to talk about. So I expanded the 90 minutes to 120 minutes. And it was productive for a lot of these individuals. So again, it's your choice on how you want to run the group. Group therapy, where a therapist is not seeing any of the clients in individual therapy, there has to be more free willing, ask for more information, take blind guesses, ask broader general questions, or call on members to describe feelings or group incident. And again, I always ask myself in any therapy, why should I work harder than the client or clients? I won't, because the client's responsibility is to work on their issues. So again, it makes a difference on how I run my individual and group therapy. Combined therapist knows too much. Yes, we do. We know their issues well in individual therapy and also in group therapy. So we know that. So, for you to be really productive and really mastering your skill in CBT, and this is just one theoretical orientation, of course, you have to know behavior therapy. Procedures have to be clearly defined. It has to be very structured, and we focus on the therapeutic process, not content. Not what is said in group therapy. You're not documenting every word that they said in group therapy. That's not the point. The point is listening for themes, processing what's going on, processing feelings. We're not focused on behavior. We're focusing beyond that, which is emotions and behavior and core belief systems for CBT. The therapeutic relationship stands to reason why it's important to focus on the importance of this relationship with the client and you, the psychologist, because the quality of trust, built into the alliance of every member of that group member, in your group of 16 people, serves as one of the more important foundations. Why they're going to trust you, why they're going to talk about their issues, even if they're not seeing you individual therapy. They want to get help from you and from the group. So there are two dimensions right there. Your assistants and your faculty, your staff and faculty's assistants, as well as how the group can help them individually. And that's why we take our time going around. But you don't want to have one person running the show all the time, running their mouth all the time. So modeling the positive constructive behavior in group, whatever they're learning in the group, they're going to learn it on the outside. Not only if they're still in prison or jail, but when they get out. So this is how group mentality becomes, is because it reinforces positive pro-social values. And we stand on consequences. Every time I run a group, there's always someone trying to bend the rules, testing the psychologist's limit settings. Well, I know a group starts at 9 o'clock, but I'm running late. I'm coming from rec, and I have to take a shower because it's a rule that we can't go from rec to your group, and it's going to take me 15 minutes, so I'll be here at 9:20. No. If I have to call and make arrangements that you're released from that, class or whatever, and you have to be on time at 9, then it's going to be like that. And if you can't make the rules, then better off not being in a group, right? Again, if they want help, assistance, they will find a way to be there, to comply with the rules, not bend the rules. But part of that is the resistance. Part of that is they don't want to be there. And they don't want to be like, oh, you mean I'm going to be amongst other sex offenders? I'm going to be stigmatized. I'm going to be shamed more. We're inside, prisons and all of that. I said, yes, you still have to. And a lot of the time when I run these groups, it's away from everybody else anyway. So nobody knows that you're even running a sex offender group. In fact, I'm not even going to advertise it as sex offender group inside of jails and prison, because you're going to be further stigmatized by others. So I'll just name it as, say, stress management group, even though everybody in the group knows that's what we're all here for. Again, there are ways around these things, and we talked about rewards and punishment. What are the rules? These are your physical boundaries, the rules. We meet in group. I mentioned that before. From what time to what time? How many sessions? What are the rules? And clearly, I would give them a handout of the rules on paper, and also it's displayed in the board or behind me, in big posters to say, these are the rules. Let's talk about the rules in session 1, because everybody needs to conform. And let's sign your informed consent so you know you're signing because you're going to be part of this group. You sign up for the group, so the rules have consequences. And it's very, very, very structured. So confidentiality versus conformity is content of individual property or of group therapy. Kind of both. But there are issues in individual therapy that's not going to come across in group therapy, and vice versa. Okay? So again, that's kind of why if you're doing compound therapy, you know what's going on because you're running the show for both IT and GT. Relevant issues pertaining to group should be brought up to group. If it's a group issue, it's breaking of the rules, then it has to be discussed in group. How many times have I stopped the group? Stopped the whole group completely. We didn't even start an issue at all. Let's say it's week 7. And everybody's thinking like, aren't we going to talk about last issue? It's like, no. Because I just found out somebody broke the rules here. Let's talk about the rule breaking. Let's talk about the rules again. Why are people not conforming to this? Because it's harming not just one person or two. It's harming the whole group. You're not going to get harmed by it, but it's their group. You're just facilitating it, right? So you have to make do with emphasizing the boundaries and conformity to such boundaries. Client resistance that I mentioned before. I kind of give you a little bit more here. We often call this opposition, reactionary, non-compliance. That's an easy word to understand, even amongst group members. You're not compliant because you haven't spoken and, at all about your issues. So maybe myself and my staff and the group, let's talk about this. And if you still want to be non-compliant, maybe you don't deserve to be in this group after all. Maybe that will push the person to talk. Or maybe the person will be pushed to say, well, maybe you really don't belong in this group. And the word I typically use with this is maybe that person is not ready. Readiness is something we assess in therapy all the time. If the client's not ready to talk about it, to function within therapy, to get better, to grow, to learn, then that person cannot be forced to do something they don't want to do. So that means we may have to put you in another group when you are ready. At this time, you're not. So again, you're assessing for that as well. Intractable, avoidance, unmotivated. A lot of the sighing, the rolling of the eyes, and all of these other things. They're not motivated. They're not learning anything, and you ask them what they learned in last week, and they don't want to tell you because maybe they didn't learn in the first place. So if it's you're unmotivated, then we need to assess that as well. Silence. You haven't spoken a word. And minimal talking. You just kind of parroting or, everything that has been said, but it's not natural. It's not your original voice or your issue. Resistance interferes with the counselor or the psychologist's perceived efficacy, impedes client motivation, and undermines the change process. Opposition. From a psychoanalytic point of view, the client's attempt to block or repress anxiety-provoking memories and insights from entering conscious awareness. We can look from a psychoanalytic point of view, but sometimes opposition is just very behavioral. Okay? A non-compliant is behaviorist. The client exhibits resistant behaviors because he or she lacks the necessary skills or knowledge needed to follow behavioral assignments. You didn't do your homework. If I'm doing CBT and group therapy, everyone is assigned a homework. Everyone has folders. Everyone has, a notebook that they could write their journals and their assignments and whatever. So if you're not doing that, then again, I have to assess your, functionality in this group. Have negative expectation or beliefs regarding their counseling outcome. Oh, I'm not going to learn anything from this. Oh, it's going to be the same thing. I've been to 14 groups already. I haven't learned anything yet. Well, then, maybe I made a mistake of enrolling you in this group. Maybe you're not ready. Okay? And are subject to undesirable environmental conditions. They're being pressured by their case manager, their counselor to be in this group so that they can document that they're doing some progress. Well, again, you're the one who is making that ultimate decision. You're the psychologist, not, a correctional counselor that has no mental health experience. So again, you may encounter such problems. So, avoidance. From a humanistic point of view, avoidance of unpleasant or dangerous feelings that may become permanent blocks to awareness and impair holistic functioning. Clients are reluctant to engage in any process that might negatively alter their life script. You would not believe how many people out there love being negative. Love their life script. They don't want to change anything. They don't want to change being a criminal, being a terrorist, being a rapist, being a pedophile or a chomo. So, again, assessing their readiness. Maybe they're not ready, and you're going to find out when they are ready or not. But I wouldn't enlist these individuals in my group if you're just going to be negative and not willing to change anything or even learn anything. Why would I put so much effort into enrolling you when I can have somebody else who's more motivated? Right. Resistance. Family systems theorists view resistance as an unconscious attempt to protect other family members by avoiding any disturbance to the delicate homeostatic balance of the system, in which change and growth have unconsciously become associated with disloyalty, betrayal, and loss. Again, from a family systems perspective, that's one way of looking at that. And I think I describe also resistance as a behavioral mechanism that you're seeing this resistance as sarcasm, attitude problem, not showing up, all of these little things. Again, so in whatever form you see resistance is something you have to continually evaluate each individual in your group, especially if they're all sex offenders. Exercise discretion and best professional judgment. Help client accept responsibility, or what we typically call accountability, or of bringing forward relevant materials to groups. They have to bring their issues forward. They have to learn something new. And one of my mandates in any therapy is they have to learn something that is, something new. One thing per person, per session. You have to tell me what you've learned. In your own words, what did you learn new that you've never learned before? And that's part of growth, is that they have to learn something new. So they have to take responsibility for that. So we're moving them from negative values to pro-social values so that, again, they can start looking forward to like going home and being out there and being functional and not having to recommit. Hopefully, in the long run. So I just kind of gave you in the next slide a saying by Ann Salter, who wrote the book Predators, Pedophiles, Rapists, and Other Sex Offenders. We mute the realization of malevolence, which is too threatening to bear, by turning offenders into victims themselves and by describing this behavior as a result of forces beyond their control. In other words, we give them a pass. A lot of people, especially politics or other people in the community, oh, they're not so bad. It's, the crime is really not that, that worst at all, or it's really not that heinous. Yes, it is. From the, put yourself as a victim or the victim's family. Yes, it was. So again, we don't want to give him a pass, because they'll do it again for the most part. And this is not typically the first time. A lot of these people have done it, right? So again, another saying by Ann Salter. Recently, I interviewed a psychopath. This is always a humbling experience because it teaches over and over how much of a human motivation and experience is outside my narrow range. Despite the psychopath's lack of conscience and lack of empathy for others, he is inevitably better at fooling people than any other type of offender. Yes, the psychopath, not a sociopath. This is a psychopath. I suppose conscience that just slows you down. A child convicted molester, this particular one made friends with a correctional officer who invited him to live in his home after he was released. Oh, I already know what the finale of this story will be. But anyway, despite the fact the officer had a 9-year-old daughter, the officer and his wife were so taken with the offender that after the offender lived with them for a few months, they initiated adoption proceedings. Adoption for a man almost their age. Unbelievable. Of course, he was a child molester living in the same house as a child. Not surprisingly, he molested a daughter the entire time he lived there. What these experiences taught me is that even when people are warned of a previously founded case of even a conviction, they still routinely underestimate the pathology in which they're dealing. See, we understand the pathology, the nature of a sex offender, because this is one above, beyond a normal, routine criminal, because they just cannot help themselves. And I'm not saying every case is like this, but this speaks volumes of what this person can do if they're not rehabilitated, if they don't learn anything, and they're not monitored, closely. This is something that they're going to do, reoffend again and again and again. And this person made a horrible mistake of having him live, with his family, and this is the result of that. So I included this because this is something that we always have to be warned in prison, and I learned this from, my older bosses, other psychologists, and so forth. Don't do a hug-a-thug therapy. And what that really means is you're being friends to these individuals, these sex offenders. They're not your friends. They're clients. You're there for a purpose. Their job is to manipulate you. Their job is to find your weakness. Their job is to look for anything that they can use against you. So be careful of what you say. Be careful of the experiences that you've had, and sharing and oversharing stories about your own personal and family experiences, your personal life. Again, I typically do not have anything working inside a prison and jail. I never had any pictures of my family. Not one. Even my diplomas are copies. I would not bring anything there of personal value or even pets. Nothing. Because anything that they can see, they can use against you. So the hug effect therapy is, again, what would you do in a situation if you have someone that's making great strides in group therapy or individual therapy and they ask for a hug? Would you give them a hug? That's a personal decision and a professional decision as well. And most of you are probably thinking, no. Or some of you will have doubts and say, oh, it's just a hug. A hug can lead to something greater because it's losing boundaries with that client with a sex offense. So again, they're looking for any chinks in your armor. Be careful. Be wary. And don't let your guard down. So the co-therapist is something that has advantages. Because I often, and it's very special when you have a co-therapist because I'm sitting on one side, they have to sit on the other side across from me if there's only two of us. If there's three of us, we're sitting in a triangular position. One to my left, the other one to my right, in a triangular position. The advantage is we complement each other. This is strategic, all right? So if you ever have worked with a co-therapist, is you strategize what's going to happen before the group even started. Complementing each other. Together have greater cognitive and observational range, can generate greater hunches and more strategies. Because they may have a different orientation approaches. They may have different educational levels. They may have different experiences as therapists in this group that you're running for sex offenders. So you want to take advantage of that. They can catalyze transferential reactions and make nature of distortions evident. That means they can look at something you're not looking at and look into that more closely, even challenge the clients who's doing this in, say, inappropriate behavior, let's say sidebar talking, when you're talking, because you're not going to see everything that goes around you. Let's say a 16 group member of sex offenders and I have two co-therapists in a triangular position. I'm not going to see every behavior. Yet my other co-therapists can see that and confront those individuals. So we look at those transferential reactions and so forth. And they can have split roles. We can do the good cop, bad cop. Love doing that. One therapist have provocative role. The other one is a nurturing or harmonizer, male and female co-therapist. You can have a combination, female-female, male-male, male-female, psychologist, whichever you prefer. But again, the strategy is to get the group talking about the issue. Not any issue they want to talk about. The issue that was supposed to be talked about that's relatable to their goals. Our goal today is to talk about emotions, the guilt, the shame that you have. And everybody else wants to talk about everything else. They want to talk about bragging about how they offended this and this and that. No, we're not doing that. We're doing this discussion. And my co-therapists are on board with me to talk about that discussion, that issue. So again, structure. Male and female therapists have a duality role that we play. It provokes images of group as a family. So you as a psychologist, as group therapist, as co-therapist, actually is functioning like a family. You're the parents in the group. You're the authority figure. Forget your age. It's all about maturity, experience. They don't know how much experience, how little experience you have. You don't need to tell them that. You don't need to divulge that information. All they know is you're the group psychologist and you're running this show with your other intern and other psychologists. That's it. They don't need to know anything else. But you're representing an image in in people's mind that you're the mother and father figure. Fantasies and misconceptions about the relation between therapists. You're setting clear boundaries with your other psychologists as well. Okay? So that means that's why it's very evident. When I'm running the group, I'm the primary, he's my secondary, she's my tertiary psychologist. There's 3 of us. There's a hierarchy involved. Or I can make the other person, the female psychologist, you're now the lead therapist. You're the primary, I'm your tertiary, he's your secondary. Whichever you prefer. Can invoke mutual respect and inclusiveness without destructive competition, mutual derogation, exploitation, or pervasive sexuality. With issues of sexual abuse, can provide opportunity to address issues of mistrust, abuse of power, and helplessness. So your representation as a family authority figure is very evident because it's going to elicit a lot of these also family issues from your group members, despite sex offense. It's going to elicit that despite their age. And that's what we want to bring out from them, is those unresolved issues that they're not willing to talk about. It's going to come out in blurts, in anger, in statements, and opinions, and all of these other things. That's what we want from them. Co-therapist lessens initial anxiety and permits objectivity because you all have different personalities. Your co-therapists have different personalities than you, even though you're the primary therapist or a psychologist. But they're thinking that there's more therapists here so they can give me more guidance about my issues and so forth, so it's going to lower their anxiety and permit objectivity. Post meetings provide valuable feedback about each other's behavior. Every time we do therapy, there has to be 5 to 10 minutes of summarizing, of checking in, and looking at issues that needs to be resolved. And if we can't resolve it in this group session that's ending, we're going to talk about it in the next group. That's the first thing we're going to talk about. So think about that. That 10 sessions of this group therapy with sex offenders is actually 10 smaller pieces of one larger group. That's how we see it. It's like one session is connected to the next, connected to the next, connected to the next. All 10 sessions put together is one gigantic group. That's how I interpret them to my clients in group, so that they don't see that each session individually is separate from each other. No, it's not. They're all connected. You're responsible for bridging one session to the next, and the next session to the next, and so forth, and so forth, and so forth. That is your responsibility as well as your co-therapist. So it aids in identification and working through countertransference reactions towards group members, and can weather group attack when there is another group therapist. Because I'm not going to catch everything, the slide remarks and the attitudes and the sarcasms and all. I'm not going to pay attention to everything. However, if I have 1 or 2 in front of me, then they can catch the things that I'm not catching. Then we can slow things down. Hey, what's that about? Why did you have to make a sarcastic remark towards your peer? Why is there a need for that? What's going on? Let's talk about this. And then everybody else is looking at that person like, well, what did I do? Well, again, we're going to confront your behavior, your responsiveness in group. And that's kind of what it is that it makes us function well if you have other people looking at some things that you cannot see. Comfortable and open to each other. And we learn to capitalize on each other's strengths, not weaknesses. So that's kind of why if that person said something, my other psychologist, let's say she's my secondary, I'm going to support what she said to say, did everybody hear what she said? Is that a good thing that you think you guys can write about and learn from and so forth? What do you think of what she said? I can manifest that. I can encourage to talk about that as an issue and so forth, because maybe some people weren't listening. So again, we capitalize on each other's strength. We don't put each other down unless that's very rare that even I have done that to other psychologists. That's strategic. We did that on purpose. Like we were fighting and everybody was, oh, look at that, they're fighting and all that, but that's a demonstration of a family fighting. What would they do? Because it's a test to the group. It's a test to the group members. If we're doing this, we want to see their reaction. We want to see what they would do if they're learning something. Rather than we're doing this in the beginning, we typically would do the good cop, bad cop in the end. Because it's a test of their learning skills. Be wary of disagreement between co-therapists or co-psychologists. It is unhelpful. The group in the initial stages of development and not yet cohesive. In the very beginning, one of the functions of the psychologist and your co-therapist is to get them to build trust. That could take a while. That could be 4, 5, 6, 7, 8 sessions later. So take your time doing that. But one of the goals of group therapy is cohesiveness, as we talked about in the very beginning. How do you make these people cohesive? Not codependent, cohesive, that they have the same goals as the individuals, but as a group they have the same goals from beginning towards the end. Because that's what you want them to do, is bring them to that fruition of accomplishing the same goals. Okay? So it mirrors parental conflict. At a later stages, it can be helpful when the group is stagnant. If the group is not going anywhere, it's not moving, they refuse to talk about their issues, let's shake them up. Let's talk about something that they don't want to talk about. Let's bring up an issue that is very painful and sore, for them to discuss. Hey, anything to move the group, right? That's exactly what our responsibility is. The disadvantage is problems between co-therapists. If you pick co-therapists or co-psychologists that you don't get along with, you have a different approach to therapy, you're going to be in conflict. So in the very beginning, even your choosing your co-therapist makes a huge difference, because you want to have similar backgrounds and similar approaches to how the therapy should go. Okay? And again, you're assigning roles to say, hey, you're going to be my second co-therapist, you're going to be my third co-therapist, I'm the primary, so I'm going to be talking in the most part, but I want you to support me. So adding problems of therapist to group therapy, no, that's a no-no. You don't get to talk about your issues because it's not your issues. This is a sex offender group. These are clients. You're not a client. You're a psychologist. You're my co-therapist. Can foster competition. That's something you must avoid. When you have another co-therapist psychologist who's competing with you because they want to talk more, I'll give you the chance, but you and I are going to talk after this group today, right? Because you're competing with me. If I feel that you're competing with me, if I'm running this show, then I'm going to make that decision. Do I really need you or not? And I'm going to talk to you as a psychologist, as a professional. Do not agree to co-lead a group with someone you do not know well. You're not just, hey, you're an intern, you have no experience, so come and join me and all of that. No, let's talk about this first. Okay, especially if the person is something you don't like. Never done that. Never will do that. Okay, because again, we're going to be clashing personality-wise, approach-wise, and that's something I don't need, because it's not for the psychologist to figure this out. It's up to the client. The client is the client's. It's for them to grow into this session. It's their session, not yours. Same-sex co-therapist versus opposite-sex co-therapist. What are your thoughts on that? It could be both, because I've read both before. I don't have a problem about gender, whether you're a male psychologist or female psychologist. It doesn't matter to me. But some psychologists may have an issue with that. So the question is more about towards you. What do you prefer? And some people have preferences. And it's a preference. There's nothing wrong with that. Unwise to have co-therapists with whom one has had romantic relationship. Completely avoid this. You're working side by side. You used to date. You're no longer dating. I wouldn't make that person my co-therapist, because your issues will come out. The husband and wife team long-term relationship differs. That's different from someone you were dating. Again, I've had a number of groups where a husband and wife actually ran the therapy very successfully because they know how to work with each other. Again, okay, sometimes that really makes a difference. You have to be mindful of subgroupings. Some group members side with one therapist, other group members will side with the co-therapist. They want to split you. We expect that. But if you have a good relationship with your co-therapist, that's never going to happen. Because you're going to talk about these issues after. There's going to be a post-meeting of therapists. There's going to be a pre-meeting of therapists. You're always talking about these things all the time before you start making notes. So I have 15 members. I have 2 co-therapists. I'm going to assign 5 for me, 5 for my second, 5 for my third in note-taking. So that way we split and we divide the note-taking equally. But again, we talk about these issues all the time, okay? Because we are one mind when we're running the therapy as a group therapist. This process should be discussed in group, and co-therapist relationship takes time to develop and mature. We have 16 weeks to do this. Maybe I'm choosing the ones, my co-therapists who I've run groups before for the last year, 2 years, 5 years, 15 years. So we've developed a relationship. We know how each other works. Okay? Because if we're a solid foundation of a psychologist group running this show, do in fact expect that you're going to have subgroupings amongst your sex offenders. Oh, the passive ones are grouping in, the bullies are one another group. The antisocial is another group. There's going to be subgroupings or what we call coalition in your groups. That's expected. But we as psychologists have to know how to manage that, how to control for that, not let one group override the other group. So that's expected too, because it's our job. Meeting before group starts, that's amongst the co-therapists. Talk about the last group session, discuss problems and issues, discuss strategies. So that person or that group tried to take over last time. So this time we're going to set more structured rules to them. They're not allowed to talk more than 30 seconds, blah, 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 whatever. So you're going to develop strategies on how to manage problematic clients, sex offenders, and then maybe bring out other people to talk more. So you're going to develop these strategies, and you're going to discuss these strategies, and you're going to debrief after and discuss the outcome of the session and reflect on what's good or what's bad. Do not be perfectionistic. You are not expected to be a perfect psychologist every time you're on the group. Okay? Pace yourself. Time yourself. Give your other psychologists or therapists or co-therapists a chance to talk. You cannot just take over and do all the work. That's what you have a co-therapist is for. So you can divide the work. All right? So it eases up on you as a primary psychologist. One cannot recall everything that's happened. So everybody takes notes like I said before. And do remember themes instead. It's important to recognize themes, not words. Or record or, document everything. It's not going to happen. From a temporal perspective, the therapist must be cognizant of change occurring every or over weeks or months of sessions, both in the group and each member. They're expected to grow. They're expected to mature. There has to be what we consider in group therapy an evolution. The group is expected to mature and evolve from day 1 to week 16. They're not the same people anymore. They've learned some things. What are those things that they've learned? Let's talk about those things. The benefit of sharing accounts of changes in group for each member. So as you move closer to termination, they're either going to be stagnant, they're going to deteriorate because a lot of these clients don't want to graduate and move on. So they want to keep talking and maintaining the same group members and so forth, which they know it's impossible because the group has to end. 16 weeks is 16 weeks, and they're going to try to negotiate with you. Okay, we have 4 more sessions because we're not ready yet. No. So it's going to force the group to say, hey, let's get ready because let's take as much time as possible learning about this because in 2 weeks we're done. That's it. Done. Okay? Unless you want to extend it, and you better have a good reason why you want to extend the group session. because you're going to be asked of that by your supervisor. But remember, this is just one group. And for the most part, if I'm scheduling a 16-man group, there's already another group coming up shortly after this group. It's already in the waiting list. They're waiting to start with you and your team. So again, you can't hold off on this, right? And the last one, summarizing. Filling gaps for members who miss meetings, and you want to control absences and lateness due to illness, vacation, or other reasons. That includes your co-therapist. If they're going to be out for a certain number of time, like, oh, they're pregnant, they're about to give birth, or they're having surgery, you need to compensate for that. You need to know that ahead of time. Okay? And you will know ahead of time. Keep updates on new group members. When you have a group that starts, it's a closed group. And I failed to mention that in the very beginning. It's a closed group. Just because we lost 4 members doesn't mean I'm going to add more. Maybe in session 1. But if I want to keep the membership below 16, I'm not going to go over that. So that means I'm not going to admit anything new. And, you're always going to have people say, hey, you know what? Week 10. Hey, can I join your group? No. It's a closed group. You're going to have to wait until the next group. So that's always important to update the group members that once they start, very similar to what you guys have in school, it's your cohort. You start with the same group, you're going to end up with the same group. So that forms closeness and cohesiveness among group members so that they're able to share more open about their issues. Written summary facilitates therapy. Sometimes they're going to ask, can I get a group summary of what I did? Okay. Because I'm making notes every week of every member that I'm responsible for. There were times when 16 member, I'm the only therapist. I'm the only psychologist. So I'm doing 16 notes every time, every week. That's a lot. But again, I didn't have co-therapists. But once I start having it, I divvied up the responsibility. Blanketed non-disclosed names of members. Okay, part of the confidentiality is this is your group, but when you leave here, confidentiality stands for a reason. You're not out there, even in the community. You're barbecuing somebody's house. You're sharing stories about somebody else. No, we're not having that. Okay, it's still confidentiality, and it's an individual choice. So that ends my lecture. If you have any questions, feel free to email me, talk to me about it during class and so forth. This audio lecture is for week 6 when we do meet, but the lecture is made it's from the week 4 and week 4. So I'm kind of switching week 4 to week 6. All right, so I'm gonna let you know that once we meet this weekend. Have a great day. If you have any questions, let me know. Hope you enjoy this audio lecture. And all you need to do, like I said, is just listen to this. And it counts as your attendance. And continue with the homework, with discussion or assignments. Thank you. Have a great day.